Chairpersons and friends, it's truly a singular honor to be delivering a lecture named after the legendary ophthalmologist Professor Daljit Singh, who had such an impact on the development of cataract surgery in our professional lifetimes. And I'm truly thankful to the leadership of the current All India Ophthalmological Society for having bestowed this honor on me. My topic is going to be why premium IOLs should be routine. It sort of syncs with the oration simply because Dr. Daljit Singh was one of the pioneers in the adoption of intraocular lenses in cataract surgery. And today we are at another inflection point where we are considering why should not we switch over to premium intraocular lenses as a routine. I've always found that whenever I prescribe spectacles, whether to a 10-year-old getting his first myopic glasses, a 43-year-old get his presbyopic glasses, or a 65-year-old after a PMMA lenses being prescribed glasses, a tinge of disappointment. Do I really need this? Can I do without it? So I think as ophthalmologists of third millennium, we need to address this. Let us look at this. In the year 1950, the average life expectancy of an Indian was 35 years. And today in 2024, it's 70, almost matching that of citizens in North America or in Western Europe. So in the last 75 years, the life expectancy of the Indian population has increased by 35 years. And this is United Nations statistics. Another important aspect is that compared to the US, where the average age of cataract surgery is 73, in India it's almost a decade earlier. It's at 65, maybe because of various factors into which I'm not going to. But we are all aware that cataract develops in the Indian population a little earlier than the Western counterparts. So it's not just the development of cataracts or the people aging. Today, the people in their 60s and 70s, like many of us, want to live a full life. They want to drive, they want to work, they want to enjoy their professional pastimes. And they believe that what they were doing in their 40s is what they should continue to do so. If hopefully, without the aid of external optical crutches in the form of glasses. A gentleman like this, would you dare to prescribe glasses without correcting his cylinder or presbyopia? In that case, why do we go ahead and implant intraocular lenses without addressing cylinders and presbyopia when we do cataract surgery? Especially when he's going to spend almost 1/3 of his lifetime possibly 1/3 of his lifetime as a pseudophakic individual. Toric intraocular lenses is a given today, and today's world, I think if there is significant cylinder, you're going to go ahead and address it. As far as multifocal intraocular lenses are concerned, there are multiple options that are available. The very fact that multiple options are available also tells us that none of them are perfect, and obviously there is scope for development. And today the current standards of cataract surgery is not just the removal of the opacity. We are concerned about the uncorrected visual acuity for all distances, distance, intermediate and near, improvement in the quality of vision, the kind of quality the patient enjoyed when they were at 20. And since the patient might live much after our own professional lifetimes, what we do today should serve the patient well for the rest of his life. So essentially, cataract surgery is not just vision restorative, but it's vision enhancing. And why has this change come about? Accurate biometry, excellent equipments, excellent formula, availability of multiple options in which we can pick and choose depending on the needs of the patient, excellent post-surgical visual outcomes where we can confidently tell a normal patient almost 99% of them will get a good visual acuity, active lifestyle and even in the 60s, which you alluded to, and obviously a desire to get rid of glasses. And the challenges of multifocal intraocular lenses, though I have been talking about it, using these lenses almost about the last 25 years, only now about 40% of my patients get it. Because it's the concerns about the quality of vision, suboptimal outcomes, where you cannot always deliver to the patient what you promise, the cost involved, the extra chair time that's involved in counseling these patients, and perfecting the workflow and changing your workflow, not just for the surgeon, but for his entire staff, and tracking outcomes, and then obviously modifying your surgical procedures so that the outcomes become better day in and day out. Why are we so concerned about multifocal intraocular and still it had not got adapted? Because it's non-physiological. Whenever we do something physiological, that is when the blood pressure goes up, when you bring it down, when the intraocular pressure goes up, we bring it down. When the lens becomes opaque, we take it out. But multifocality was never in the scheme of things as far as nature is concerned, either in the cornea or in the lens. No visual system is multifocal in any mammal, and we go against physiology. Obviously, there are going to be complications that we have to live with. So what exactly I do in my counseling, or rather I encourage my staff to do, is essentially to not to promise the moon. It's just a less dependence on glasses and not sentences like throw your glasses, or counsel them about dysphotopsia. Bilateral surgery always helps. And just in case the refractive outcome is a little suboptimal, a touch-up procedure might be necessary. And neural adaptation is a big friend of ours. And just in case you allow the tincture of time, many of the initial problems tend to go away with. And it's most important that we stay away from this concept of too much information syndrome, where we talk right from PMMA intraocular lenses with up to a trifocal toric and with laser cataract surgery. Obviously, you decide what the patient needs, what the patient can afford, what the patient wants, and your entire counseling should be directed accordingly. You might think that all these modern gadgets are necessary for doing good premium intraocular lens surgery, but I feel though those gadgets do help, essentially as far as you have access to an optical biometry or even an excellent immersion A scan, a standardized repeatable autokeratometry where the surgeon or the technician doing it is as important as the equipment itself, access to excellent formula which is even available online, good repeatable phaco techniques where you get predictable refractive outcomes with predictable corneal astigmatism, and essentially you have a complete understanding of the intraocular lenses that you are dealing with. Then you are good to go as far as premium intraocular lenses is concerned. I think these are the aspects that I would do just in case there is a residual sphere or a cylinder. And I think the second eye surgery is an excellent concept as far as addressing good outcomes in premium intraocular lenses is concerned. Depending on the outcome in the first eye, we not only optimize the IOL type and the power of the fellow eye, and I usually give about 2 weeks between the two eyes of the surgery, so that bilaterally implanted, these patients can function quite well, most often without the need for glasses. And once you have implanted both eyes, cortical adaptation also becomes better and provides a range of continuous vision, which maximizes image quality and also reduces photic issues. It's most important to understand that we perceive with the eyes but see through our brain, and neural adaptation is both the challenge and as well as the solution. As far as neural adaptation does not occur, the patient has a problem, but once he or she adapts to the new optical system that's presented to them, then the problem seems to go away with. Unfortunately, in about 90% of the eyes, younger the patient, the better the neural adaptation, the problem gets sorted out over a period of time. It is important that the patient counsels patients to his patients in the times when they go through this difficult period. And you might be concerned about the cost. There are obviously several multinationals coming out with excellent products. But the good news is that the Indian ophthalmology technology has also progressed by leaps and bounds. And now there are several toric lenses, multifocal lenses, toric multifocal intraocular lenses, which we can proudly place from our own companies. 50% of the premium intraocular lenses that we do in our centers is from Indian companies. And it's extremely important that you tell you are able to tell your patients about the power of experience. This gentleman came with a problem of slight difficulty in driving. I said that I can exchange your lenses, replace your multifocal intraocular lenses, but that's what we'll see. Provide a -2 diopter. I have this as a standard practice. Then I put these -2 diopter lenses on his eyes and say, this is what you will see if you have these lenses on, if I exchange your lenses. And in case this is what you have with your current multifocal intraocular lenses. Once I do this, once they understand the benefits that has accrued from this technology, they are willing to live with what they were given. I think it's most important. This slide has not changed from my days I was doing intracapsular cataract extraction. Whenever a patient comes to us with a problem, it's more an observation. It's important that we understand, make them realize that we are with them, we know what their problem is, and we can solve it together. The patients are more concerned about how much you care than how much you know. As far as you are with them, most often you can get them sorted out. I think it's something we always need to keep in mind, that as ophthalmologists, we cannot add age to the life of our patients, but we can add life to the age of our patients. And towards that, I do believe as a cataract surgeon that premium intraocular lenses have come to stay in this millennium of ophthalmology. Thank you once again for this wonderful opportunity to deliver this oration.